well as I believe in this one, we talked about how there are other neurotransmitters that we weren't going to discuss at that time, but then we would discuss them sometime in the future. Well, this is the future, and we're going to discuss them. So we know that epinephrine, norepinephrine, and acetylcholine, their major job is excitatory. They are going to transfer the signal from one neuron to another neuron, or they're going to transfer the signal to a muscle or gland and cause something to happen. And so in the majority of them, we'll have an excitatory response. There are occasions in some areas where there might be some inhibitory response, but the majority is excitatory. Histamine, we've talked about histamine receptors. If you remember, we talked about them in the parietal cells of the stomach. And so when the histamine receptor is stimulated by the neurotransmitter histamine, we will have an excitatory response. We're going to talk a lot today about GABA, dopamine, and serotonin. And when we talk about those, the majority of them are going to be inhibitory in nature. And it'll make sense when we start looking at how some of the medications work on the brain. So when we talk about sedatives, what we're talking about are actually medications that cause sedation, as well as some of them cause some sort of hypnosis. But we also are going to talk about sedatives that are designed for anxiolysis, which is relief of anxiety. And so I know a lot of your patients, when you go over their medical histories, a lot of them are taking medications for anxiety. So when we look at the different classifications of sedatives, we're going to talk about the benzodiazepines, we're going to talk about barbiturates, we're going to talk about some antihistamines, and then there's a few others. Now, when we talk about sedatives, there are quite a few side effects when we look at sedatives. Sometimes when someone takes a sedative, instead of getting sedated, it actually acts as an excitatory response. So a side effect for some individuals is that when they take the medication, instead of calming them down, it hypes them up. So that is a side effect for some individuals because they'll actually get stimulation of the central nervous system. Sedatives will cause respiratory depression. They will also cause cardiovascular depression. So when someone overdoses on sedatives, again, when we're looking at, like when we looked at opioids, we had respiratory depression and cardiovascular depression. So people can die from overdosing on sedatives, and typically it's related to respiratory depression and cardiovascular depression. And people can become dependent on them. So you're going to have individuals that may be taking medications for anxiety for a long period of time. So they're chronically taking those medications, and eventually their bodies become dependent on those medications. If you take them off of those medications abruptly, they can go through withdrawal. And then one of the biggies is REM depression. REM is rapid eye movement. So when we're sleeping, when we get the best sleep, it's during the REM sleep, when we have the rapid eye movement. And so when you are sleeping at night, there's only a period of time that you're actually in that REM sleep period. And that's when you get the most rested. So when you wake up in the morning, you feel rested because of that REM sleep. When people take sedatives, what happens is that they get depression of that REM sleep. So someone can take a sedative and sleep for 8 to 10 hours and wake up and not feel rested. And that's because of the depression of that REM sleep. So if we look at some of the different effects of these medications, we're going to look at benzodiazepines, barbiturates, and antihistamines. So when we look at the efficacy against anxiety, so if a medication or a patient is taking a medication for anxiety, we get a very good effect with benzodiazepines. And that's typically why someone is taking some sort of a benzodiazepine when they have anxiety. Now, you will get a little bit of anxiety relief with barbiturates, but the only way to really get relief from anxiety is to go to sleep because you took those barbiturates. So it sedated you so much that you no longer have the anxiety. With antihistamines, there is no anxiety relief. So if you are feeling extremely anxious and you take a Benadryl, you are not going to get relief from that anxiety. But if you take enough Benadryl, you will get sedated enough that you will no longer have anxiety. So again, it is if the only way to really get good anxiety effect with these medications is to take enough that you get sedated, and therefore it relieves the anxiety. So if you want to try to stay awake and relieve that anxiety, then benzodiazepines are the better choice. And that's why your patients are not taking Benadryl or barbiturates for their anxiety. Now for sedation, if you give the patient enough of a benzodiazepine, when we do conscious sedation on our patients in the dental office, quite often we use a medication called midazolam or Versed. And this medication is a benzodiazepine. And it is a great medication for sedation. Barbiturates also will cause sedation. They have a very good effect of sedation. And antihistamines also have a pretty good effect. Obviously not as much as benzodiazepines and barbiturates, but it does have good sedation effects, okay? Now, when we look at the therapeutic index, that's an important thing because barbiturates have a very low therapeutic index. So there's a greater risk when a patient is taking a barbiturate than if they're taking an antihistamine. All right, so typically people are not going to overdose on antihistamines, but they can easily overdose on barbiturates, and we can start to see some of those toxic effects or those bad effects with barbiturates with just a small amount of the medication. With benzodiazepines, it's kind of in the middle, so they're relatively safe, but obviously of the three of these, antihistamines are the safest, which would explain why you can buy antihistamines over the counter. You cannot go to Walgreens and look at the shelves and find barbiturates and benzodiazepines, I hope. Okay? All right, anticonvulsant. If someone is having seizures, benzodiazepines are the drug of choice if someone is having like the status epilepticus, so they're having those constant seizures that are going on and on and on, or one seizure that's lasting for a long period of time. Benzodiazepines are great as anticonvulsants, and so they're the drug of choice that we give those individuals who are having that status epilepticus. Now you can also get anticonvulsant with barbiturates, but again, because of that low therapeutic index, it's a greater risk to give those people those medications. So if we have to choose which one is the safest and has anticonvulsant activity, benzodiazepines are a better choice. Now, anterograde amnesia means that not only are you going to have amnesia while you're on the medication. So if you take the medication, gets into your system at 2 p.m., you're going to have some amnesia from 2 p.m. until that medicine starts to wear off. With anterograde amnesia, you will also kind of lose some memory prior to the time that you took that medication. So think of if you go into the office to have wisdom teeth out and they give you a benzodiazepine in your IV. Once you get that benzodiazepine in your IV, you are not going to remember that appointment. So we will talk to you, you will answer us, If you're feeling pain, you will tell us and we'll numb you some more. But once that medication wears off, you're not going to have that memory of what happened in that office. The other thing is you may not even remember coming to the office because of that anterograde amnesia. Okay, you knew that you had an appointment, but you have no memory of how you got there and then what happened in that office. Okay? Now, there is no anterograde amnesia with barbiturates or antihistamines. Antiemetic is for nausea. Okay, it's going to help you to not throw up. And so benzodiazepines and barbiturates are not good medications for nausea. Antihistamines have a pretty good effect to help with nausea. And then dependence, when we look at when people are taking medications long term, if their bodies are going to build a dependence, you have a higher chance of building a dependence with barbiturates, moderate with benzodiazepines, and no chance of getting dependence on a Benadryl or an antihistamine. Okay? Does everybody understand everything on that table? Okay. All right, so let's look at how benzodiazepines work. And what we're going to do is we're going to look at some chloride channels within the membrane of the neurons. Okay, so the cell membrane of the neurons have chloride channels on them. So what happens is that the chloride channels, if they're open and allow that chloride to enter the cell, they are going to reduce the excitability of that neuron. So the chloride is able to get through those channels. When it gets into the nerve, it is going to prevent or lessen the excitability of that neuron. The way that they open is that the neurotransmitter GABA causes them to open. So remember we said GABA was an inhibitory neurotransmitter. So GABA will actually cause these chloride channels to open, which will allow the chloride to enter the neuron. When the chloride enters the neuron, it will lessen or inhibit the excitatory effect of that neuron. Now with benzodiazepines, they will increase the GABA response. So when you have GABA, you get the opening of the chloride channels. When they have benzodiazepines on board as well, it opens those channels even more. So to a greater extent, so more chloride can get in, so it's going to inhibit that neuron even more. So GABA will lessen the excitability, the benzodiazepine will increase that to inhibit it or lessen it to a greater extent. Okay? Now the interesting thing about benzodiazepines are, if there's no GABA present, the benzodiazepine does nothing. So the benzodiazepine in itself cannot open a chloride channel. So you have to have GABA present in order to have the benzodiazepine increase that GABA response. Okay, is that making sense? So if you have benzodiazepine, no GABA, nothing happens. It doesn't inhibit that stimulation of that neuron. But if you have GABA and benzodiazepine, then you greatly diminish the excitability. If you just have GABA with no benzodiazepines, you are diminishing that excitatory level, but not to the extent as you would if you had benzodiazepines on board as well. So when we look at benzodiazepines, there's several of them, and they all have kind of different durations of action. And so their durations of action are going to be dependent on whether the drug itself is the active portion or if the metabolites are active. And you may have one or more metabolites that are active. Sometimes the parent drug and a metabolite are active. So when you have those cases, then you're going to have a longer duration of action. Lipid solubility, we know about lipid solubility. The more lipid soluble a drug is, the faster it's able to get into the cells. So if it has a higher lipid solubility, the onset's going to be faster, but the duration is going to be shorter. And then the half-life, if you just take a single dose of a benzodiazepine, the half-life really doesn't have any effect at all. Theoretically, if you use benzodiazepines long-term, then it could have an effect on the duration of action, but because of the tolerance that the body will start to build with that drug, it usually offsets the change in the half-life. So typically the half-life does not have much of an effect of the duration of action. So here are a bunch of benzodiazepines. I am not going to make you to memorize the doses or the onsets, the half-life. What we want to look at is that Valium or diazepam, that's the prototype for benzodiazepine. So when you think of benzodiazepine, the first one you should think of is Valium. All right? So Valium or diazepam, the parent drug is active, but there's also a metabolite that's active. So because of that, we have a longer duration of action with diazepam than we have with some of the other benzodiazepines. Some of the other ones, the ones that I have that are kind of marked with the blue names, those are the ones that I want you to know. Okay, so know that Valium or diazepam is the prototype for benzodiazepines. And then these are the most common ones that are used. Most of the time people aren't using Valium anymore. Sometimes they'll use it for sleep, but typically they're using some of the other ones because of the fact that the Valium has effects for a longer period of time. So if somebody would take a Valium during the day, they're going to have some of that sedation, they're going to have some of that amnesia, and it's going to be over a longer period of time. But some of the other ones, we have alprazolam, which is Xanax, lorazepam, which is Ativan, temazepam, which is Restorol, and then triazolam, which is Halcion. And I would say most often when a dentist is prescribing something for anxiety related to a dental appointment, they're typically going to prescribe either Ativan or Halcion. So you may see that not necessarily when you have a patient in the chair here, but when you go into private practice, you may see that your dentist is prescribing those specific medications as an anxiety. Sometimes they take it HS. Everybody remember what HS stands for? At bedtime. So they'll take it at bedtime the night before the appointment. And then they usually will take another one like an hour before the dental appointment just to help them with that dental anxiety. All right. Another benzodiazepine is a roofie. Okay, date rape drug. It's a benzodiazepine. And so what happens when someone takes a roofie? They wake up somewhere. They're not sure what happened, but they think they know what happened because of how they feel, but quite often they have no memory of what had happened. Okay, so again, Valium is the prototype. All right, so just remember with benzodiazepines, they have a high therapeutic index, so they're relatively safe drugs. They do cause some muscle relaxation. So you know during a seizure, when we have the tonic-clonic type of seizure, where you get tonic is that muscle tone where everything gets really tight, and then the clonic is when they get the rhythmic movements. So that's why one of the reasons we use benzodiazepines is to help with that to relax those muscles during those seizures. And it also will help with the clonic portion where you're having the rhythmic or the spastic movements. And then again, anterograde amnesia, which is good if they're coming in for a dental appointment. It's not so good if it was in your drink at the bar last night. Now, sometimes people can get too much. Okay, sometimes if you have them in the dental office and we're giving them some Versed, we kind of tip it over and it's like, yeah, I think we need to stop some of these effects. So there is a reversal agent for benzodiazepines. It's called flumazenil or romazicon. Flumazenil is the generic and romazicon is the brand name. But if we give them this reversal agent, it will reverse the effects of the benzodiazepines. All right, some other GABA agents. Sometimes people have issues with insomnia, and so they'll be prescribed an Ambien. An Ambien is not a benzodiazepine, but it is a GABA agent. Okay, so with the GABA then, it's going to increase or open those chloride channels, which will then cause an inhibition of the excitatory response of a neuron. Lunesta is another one that's used for insomnia. There are barbiturates are GABA agents. I don't expect you to memorize all of the names of the barbiturates. Just realize that there are some that are short acting, some that are long acting, some that are ultra short acting. The important thing to remember is that they have a very low therapeutic index, and they are known to cause respiratory depression. And so with that low therapeutic index, if you go over just a little bit, then you're significantly depressing their respiration or their respiratory drive. They also will cause an increase in the enzyme activity in the liver. And we know that drugs are broken down in the liver, right? Through uptake 3. Does that all sound familiar? Yeah? Sorta, maybe? Okay. And so if we increase that enzyme activity in the liver, how is that going to affect other drugs that individual's taking? It's going to break them down quicker, so you may have to increase the dose. The problem is how much. It's very difficult to determine how much you actually have to give them because of the increased breakdown. So if they're just taking it short term, it's usually not an issue, but if they have to take them chronically for some reason, then it is going to cause an effect. And so they do have the greatest effect on the metabolism of other drugs that individual is taking. And then meprobamate is another GABA agent. It's interesting, when I worked for the orthodontist, when I first got out of dental assisting school, I worked for an orthodontist. And every patient that he was going to put bands on, he gave them meprobamate. Because you have kids, what kids want to do, squirm around in the chair. So he gave them those to settle them down. And it worked great, but he was the only orthodontist I've ever known that did that. And then ethanol. So if we look at chloral hydrate, a metabolite of chloral hydrate is a form of ethanol. So ethanol is a GABA agent as well. Okay, so when we look at antihistamines, we know that we have H1 receptors and we have H2 receptors. So we're going to start out looking at H1 receptors. And so an antihistamine, it would be an antagonist at H1 receptors. Is it a ligand? Yeah. All right. So if those H1 receptors are in the peripheral nervous system or the peripheral portions of the body, it's going to help to inhibit inflammation. For the central nervous system, it causes sedation and anti-nausea. So when we have a bee sting or a spider bite or something that we're having a cutaneous sensitivity reaction to, and we take a Benadryl, in the periphery, it's going to inhibit that inflammation. Okay, so it's going to stop it from swelling, or lessen it from swelling. It's going to help with itching and all those histamine reactions. But it also will cause sedation. So if you take one pill, you might get a little bit of sedation. Some people it affects more than others. You take two, then you're going to have more sedation. And then it also helps with anti-emesis, which is the anti-nausea. The problem is if you're nauseated and you take a pill, if you're throwing up, you're just going to throw up that pill. So a lot of times, if you need to take an antihistamine as an anti-nausea or an anti-vomiting medication, it's going to be one that you're going to put up your butt. Okay, so that you won't throw it up. Okay, so think of Phenergan. People take Phenergan, and it's usually a suppository, so that you don't throw it back up. Yes.
So, like, I know, like, I've never heard of like people using antihistamines for this. Like, I have like really sensitive skin, so like if I use something like different, like I break out really, really bad. And if I like take an antihistamine for the next couple of days, like my skin clears up. Like, how does that work? Like,
It's because you're having a histamine reaction.
okay.
You're having a cutaneous histamine reaction. So you're taking antihistamine to block those receptors so that the histamine that's being released is not attaching to those receptors. Okay? Another use that people have for antihistamines, which I do not recommend, but a lot of parents with young children who have to fly, I hear how a lot of them will give their babies or their children Benadryl so they'll sleep on the plane. So you may hear people doing that. I absolutely do not recommend that because you're giving somebody a medication that they don't need. All right, and even though it has a high therapeutic index, you just don't know. So I would not recommend that, but I've heard of many people that do that. All right, antihistamines are also antagonists at cholinergic receptors. So with the cholinergic receptors, it also is going to help with anti-vomiting. It is also going to cause some sedation, and it also causes dry mouth. So sometimes when you take an antihistamine, you'll notice that your mouth gets kind of dried up as well. And that's because of it affecting or being an antagonist at the cholinergic receptors. You don't get any good anti-anxiety with antihistamines unless you take enough that it starts to sedate you. And again, they have a high therapeutic index, so they're relatively safe, but only use them for what they're designed for. Don't use them for other things. All right, and there are some non-sedating antihistamines. So you've probably seen on the market like Claritin, Allegra, and Zyrtec. And they're designed to work as antihistamines, but they don't cause sedation. And that's just because of the way that they happen to work. They affect more of the periphery and less of the central nervous system. And that's why you don't get the sedation. You still can get sedation. Some people can still take these medications and get some sedation, but in general, it doesn't cause the sedation as the other antihistamines do. All right, and the reason that they don't cause that sedation is because they have a lower lipid solubility than the other antihistamines. so it doesn't get absorbed within the central nervous system like the other antihistamines do. All right, H2 blockers. These are the ones that are going to help to reduce the amount of acid that's produced in the cells of the stomach. So we looked at the parietal cells earlier. Some of those H2 blockers, one of them is Tagamet, which is cimetidine, Pepcid, which is famotidine, Zantac, which is ranitidine, actually is no longer on the market, but you may see questions about it on your board because of the fact that it was on the market for a long period of time. The reason it was taken off the market was because they found that some of the ingredients within the medication could possibly be carcinogenic. So it was removed from the market, but again, you may still see questions about it on your board, and that's why I left it in on this slide. And then Axid is another one. So the H2 blockers, these are antihistamines, but they're specifically designed to block the H2 receptors in the stomach. By blocking those receptors in the stomach, you produce less acid in your stomach. All right, any questions about antihistamines or benzodiazepines? Okay. All right, so now let's look at some psychotherapeutics. When we look at psychotherapeutics, there are some medications that are antipsychotics, there are some that are antidepressants, and there's some that are antimanics, which are medications for bipolar disorder, okay? You will have, I've seen a lot of patients that are taking medication, of your patients that are taking medications for depression. I've seen a couple that they were taking some for bipolar and some they were taking some for antipsychotic, but the majority of them were taking antidepressants. When we look at antipsychotics, the way that they work is that they block dopamine receptors, specifically the ones that are in the limbic region of the brain, okay? These dopamine receptors are called central dopamine receptors. So the job of the antipsychotics are to block the dopamine receptors in the limbic region of the brain. Now we have dopamine receptors in other areas of our brain, and it's going to block those as well. They also will affect other receptors such as cholinergic, histamine, and adrenergic receptors. So the job we want it to do is to do this. But they're also going to do block the dopamine receptors in other areas of the brain, as well as do some blocking of some other receptors that are not dopamine receptors. And so because of that, these are going to cause side effects. So this is the wanted effect, and these are side effects. A lot of patients do not want to take their antipsychotic medications because of the side effects that occur. So even though they know it will help them with this, they don't like the side effects, so they don't take their medications. So when we look at the different neurotransmitters, we said that the antipsychotics block dopamine, as well as some cholinergic, some histamine, and some adrenergic, specifically alpha. So this is the wanted effect, okay? So it's going to block the dopamine receptors in the limbic region of the brain, and therefore we're going to get an antipsychotic effect. That's the wanted. So the plus means it's a good effect. It also is going to affect if the patient is nauseated. So it's going to be an antiemetic. That's not really a positive or a negative because the patient's not taking that for nausea. If you're sick to your stomach, we're not going to prescribe you an antipsychotic. for your stomach. And so it's really not a positive or a negative, because the patient is typically not, I guess if the patient was nauseated, it would help. But in general, if someone's taking this, they're not nauseated, so it's really going to have no effect. It's not going to prevent nausea if you don't have it. It also is going to affect or block the dopamine receptors in the basal ganglia. And when that occurs, we're going to see some extrapyramidal effects. I'm not going to go into that yet because we go in depth in that in a couple of slides, okay? But this is a negative effect. This is a side effect. And then it also can affect the dopamine receptors in the hypothalamus, and we can get something called galactorrhea, which means that you get a discharge from your nipples. That is not breast milk. It's a milky white discharge, but it is not breast milk. So that obviously is a bad effect. People don't want to have that oozing out of their nipples. And so this is also a side effect. When we look at the cholinergic receptors in the central nervous system, it's going to cause sedation. This is one of the big reasons why people don't want to take antipsychotics, because it makes them feel they're sedated. They just don't feel like they're selves. They don't feel like they can do anything, okay? It also has some antiemetic, which again is not positive or negative because they typically are not nauseated. In the peripheral nervous system, it causes constipation and dry mouth. Those are both side effects, and they're unwanted side effects. When we look at the histamine receptors in the central nervous system, again, we get sedation. So now we're getting sedation from the cholinergic as well as sedation from the histamine receptors. And again, have an antiemetic, which is not a positive or a negative. In the peripheral nervous system, it is an anti-itch. Well, again, you're not taking an antipsychotic because you're itching. And so it's really not a positive or a negative effect. When we look at alpha receptors, we've got sedation again. Okay, so another side effect with that sedation, patients don't like to feel like they're sedated all the time, and that's why they don't like to take the medication. And then the peripheral nervous system, hypotension. So when patients are taking antipsychotics, you have them in the dental chair, you sit them up quickly, they get up, they pass out because of that orthostatic hypotension. Okay? All right, so let's look at the pyramidal and extrapyramidal tracts. When we look at the pyramidal tract, what the pyramidal tract is that it's just motor neurons that are involved with the voluntary, fine, and skilled movements. Okay? So when you want to move your arm, that's a voluntary movement that's related to the pyramidal tract. The extrapyramidal tract is the motor system that's involved with involuntary action. So we're looking at reflexes, complex movements, and posture. So if we are affecting our extrapyramidal tract, we can cause patients to have these rhythmic movements. Okay, so you've probably seen maybe some commercials on TV when they're talking about patients are taking certain medications and they have that tardive dyskinesia. Does that sound familiar to anyone? No, well, tardive dyskinesia is that you have this involuntary tick or movement of your hand. So, you're just constantly like this. It kind of looks like Parkinson's, but it's only related to certain areas, okay? So, here we have a brain. Here's the cerebral cortex. Here's the basal ganglia. So, within the cerebral cortex, we're dealing with the pyramidal tract. The signals come from the cerebral cortex to the skeletal muscles, and it will excite those skeletal muscles. So when you decide you want to lift your arm, your cerebral cortex is going to send the signal down, and it will stimulate the skeletal muscle, which will allow you to move your arm. Okay? When we're looking at the basal ganglia is related to the extrapyramidal tract. With the extrapyramidal tract, dopamine is the neurotransmitter. As the signal comes down from the basal ganglia, it will have an inhibitory effect on the skeletal muscles. So dopamine has an inhibitory effect on the skeletal muscles. So that means if I'm just standing here, the last thing I want is for my arm to start doing this. Okay? And so my basal ganglia is releasing dopamine that's telling my arm to sit still until body tells you to move. Okay? All right, so if we block that dopamine with that antipsychotic, we are then blocking the inhibition of those skeletal muscles, and that's why people get these tics when they're taking antipsychotics. All right, so this is that tardive dyskinesia. All right, so there are several drugs. We don't have to memorize all of them, okay? But you can see how their side effects, some will highly affect the extrapyramidal tract, some will have some sedation effects, and some will have some of those autonomic effects, okay? And each one is a little different, so the medications are chosen based on how the individual reacts to certain medications, okay? So if you have someone who has a lot of problems with the tardive dyskinesia, then you try to avoid the medications that are going to have those extrapyramidal effects. So the ones that I want you to know are the Thorazine, okay? When we look at Thorazine, it has a higher effect on the autonomic system, a higher sedation effect, but it has a moderate effect on the extrapyramidal tract. And then I want you to look, I can't even read it. The Haldol. So the Haldol has a higher extrapyramidal effect, low sedation, and low autonomic effects. And then we're going to look at Risperdal here in just a little bit. But if you look at Risperdal, it looks like a great medication because it has very little extrapyramidal effects. The effects are related to the dosage. It has a low sedation and a low autonomic, so it looks like it's a great drug. But there are some other things, and we're going to look at why it has some side effects as well. All right. And then there are a couple other ones that I do want you to know. Abilify and Seroquel are also antipsychotic medications. All right, so if we compare, again, we're just comparing the Thorazine with a couple of the other ones, okay? And again, you don't need to know the dosages or any of that. But I want you to be familiar with, if I asked you which one of these meds have a greater risk of your patient passing out on you at the end of the appointment, what would you say? Thorazine and Mellaril, right? Okay. Which ones are going to have a greater chance of your patient having that tardive dyskinesia? The Compazine and Haldol, okay, because of the extrapyramidal. So those are the things that I want you to kind of get from this table. All right, so let's look at Risperdal, because again, when we looked at that list, I thought it looked great that there were relatively few side effects with Risperdal. Here's one problem with Risperdal. It actually caused growth of breast tissue in men. So if you give Risperdal to men, they are going to grow breasts. Okay? It also can affect type 2 diabetes. So the individual may not be a diabetic, but once they start taking Risperdal, it can actually cause the effect where they can become a type 2 diabetic. Elderly people, the literature has shown that there is an increased amount of death in the elderly people for those who are taking Risperdal compared to those who are not. And this is a biggie, anger management issues, where people can have explosive anger issues. So you'll be sitting there and I walk up and I hit her mouse, okay? Well, that might annoy her normally. She's probably not going to say anything. She's going to probably think something bad about me, but she's not going to say anything to me, right? But if she's on Risperdal, what could happen is I come up here and I touch her mouse. She gets so pissed off that she throws the computer at me, okay? She has this explosive anger reaction, all right? And then she gets kicked out and she never becomes a dental hygienist. So you don't want her to be on Risperdal, okay?
Not live.
All right, and dyskinesia. So we can see that the extrapyramidal, even though it is, when you looked at that list, it had a 0 and a plus. It was related to dose. And so if an individual has to take a higher dose of it, then the amount of dyskinesia will increase based on the dosage of the medication. And then there's some others that we're not going to look at, but these are the biggies. These are the biggies. All right, so any questions about the antipsychotics? You good with that? Okay, let's look at some antidepressants. So the reason individuals take antidepressants is because what we need the medication to do is it's going to increase or prolong the levels of these neurotransmitters within the central nervous system. So it's going to increase or prolong the levels of norepinephrine, serotonin, and dopamine. Now when we look at these medications, some are more related to norepinephrine, some are more related to serotonin, some are a combination of these, and so we're going to look at these. All right, so this is just a reminder again. We know that we have the 3 uptakes. When we look at drugs go through uptake 3, and then depending on whether it's a catecholamine, then it is broken down mostly by COMT. If it is a non-catecholamine, it's broken down more by MAO. And so we have heard of drugs that are called MAO inhibitors. You may have a patient who's taking an MAO inhibitor. So when we look at an MAO inhibitor, its job is to block the breakdown of norepinephrine. So the norepinephrine that's within the central nervous system, it stays around longer because it is being blocked by the MAO. Now with tricyclic antidepressants, and I know some of you have had patients that are taking a tricyclic antidepressant, their job is to inhibit the reuptake of norepinephrine and serotonin. So now we have that neurotransmitter in the synapse, and instead of it being reuptook, I don't know if that's a word, but I'm going to make it a word, it's going to stay around longer within that synapse. Then we have, I know I've seen people that have had patients that were on SSRIs. Did any of you knew what an SSRI was? Or you just wrote down because that's what well, thank you for the disclosure. Okay. So an SSRI is a selective serotonin reuptake inhibitor. All right? So what do you think an SSRI does? It inhibits the reuptake of serotonin. Okay? So SSRI is selective serotonin reuptake inhibitor. We also have some antidepressants that are called SNRIs. SNRIs are serotonin and norepinephrine reuptake inhibitors. So they're going to inhibit the reuptake of both serotonin and norepinephrine. And then there are some other ones. There are some norepinephrine reuptake inhibitors. There's some norepinephrine and dopamine reuptake inhibitors. And there are some serotonin, norepinephrine, dopamine reuptake inhibitors. Okay? Wellbutrin is a very common one. A lot of people take Wellbutrin when they're trying to quit smoking. Okay? Wellbutrin is a norepinephrine dopamine reuptake inhibitor. So what are some precautions when someone is taking one of these antidepressants? Well, with MAO inhibitors, they have to be careful about eating foods or taking certain drugs that contain tyramine. All right, so in the case of some medications, Demerol and some over-the-counter decongestants contain tyramine. So they want to avoid that. And they also have to avoid some cheeses and wines. Okay? We don't have to worry about someone taking an MAO inhibitor when we give them epinephrine containing, or a local anesthetic containing epinephrine. Why do you think that? Is epinephrine a catecholamine or a non-catecholamine? Catecholamine. How is it broken down? Uptake 3, but specifically COMT, not MAO. Okay, that's why if someone's taken an MAO inhibitor, we are not concerned about giving them local anesthetics with epinephrine. That's why when someone is taking an antidepressant, when you have the list of a name, and then afterwards you say antidepressant, that tells you absolutely nothing. Because if it's an MAO, we're not worried. If it's a tricyclic, we are worried. Okay? Because if someone's taking a tricyclic antidepressant, giving them epinephrine can not only cause a hypertensive crisis, it can also cause an arrhythmia. So that's why we want to be specific with the medications, just like the blood pressure medicines. You know, you don't want to just put it's an antihypertensive. We need to know what kind of antihypertensive it is. When they're taking an antidepressant, we need to know what kind of antidepressant it is. All right, with the SSRIs, these individuals will have fewer side effects, but sometimes they will get a opposite reaction than expected. So they may be stimulated more than sedated. We know that we had talked about some sedation that can occur, but sometimes some patients will react the opposite, and they'll actually be stimulated instead of sedated. All right, the SNRIs, which is the serotonin norepinephrine reuptake inhibitors, are quite like the tricyclic antidepressants. Okay, if we go back, let's go back to the tricyclics inhibit the reuptake of norepinephrine and serotonin. All right, SNRIs inhibit the reuptake of serotonin and norepinephrine. All right, so they're pretty much, they do the same thing. They're different medications, it's a different mechanism of action, but the effect is the same. So if an individual is taking an SNRI, we want to be careful about the epinephrine again, because we can get the same reaction like we did with the tricyclic agents. And what's interesting is that if they have recently used an MAO inhibitor and are now taking an SNRI, it can potentiate the reaction with the epinephrine. So if they've recently taken MAO inhibitor and they are now taking SNRI, we absolutely want to avoid epinephrine in those individuals. All right, so the ones that I want you to know, Prozac is probably the most common SSRI. You want to know Cymbalta as an SNRI, and that was it for those. Okay, so now when we look at antidepressants, we're looking at some different ones here. We can see whether they inhibit the reuptake of norepinephrine or serotonin or both. And then we can see what their major side effects are, okay? So as we look here with Prozac, we can see that it's a little bit of inhibition of reuptake of norepinephrine, but a high level of inhibition of the reuptake of serotonin. But if we look at the side effects, the orthostatic hypotension is only a problem based on the amount of Prozac they're taking. So there's a little bit of a effect, but not nearly to the effect of some of the other ones. Okay, any questions about antidepressants?
Did you want us to know every single thing?
I don't want you to know every single name. I want you to understand the difference between the classifications. So when someone tells you that they're taking an antidepressant, I want you to look it up and see what kind of antidepressant it is. Okay, so I'm more concerned. The ones that I circled and had the blue and all
Right.
those are the ones I want you to know. Yes.
Why do people take it? Why don't they have meaning on them and I can take it for headache, and that's like a low dose for my.
Yes, and that's a side effect that is being used as treatment. So there are some people that are taking antidepressants for migraines.
How does that work? Sounds on the image of a real low dose of it.
And it's related to the reuptake of the neurotransmitters and how it affects the vessels within the brain. And it's like, yeah, they found that certain antihypertensive medications, propranolol, they're treating people with propranolol for migraines. They're treating people with antidepressants for migraines, and what they found is it's because of it, the side effects of the medications help to treat the migraine or prevent the migraine. All right, so let's look at antimanics now. So we're looking at treatment for bipolar disease. The prototype for antimanics is lithium. Okay? Antimanics or the bipolar medications have a very low therapeutic index. So again, you're going to see side effects at a quicker than you would with some other medications because of the low therapeutic index. And you want to avoid, if the patient is taking lithium or some sort of a bipolar medication, antimanic medication, we do not want them to be using NSAIDs over a long period of time, because the NSAIDs will actually cause an increase in the serum levels of the lithium, and because lithium has a lower therapeutic index, they can have some toxic effects. All right. And that's all we need to talk about with antimanics. That was nice and easy. Just know that slide, okay? All right, let's talk about anticonvulsants, okay? So the way anticonvulsants work is that they either will prevent the excessive discharge. When a seizure is starting, it usually starts at one spot and then it spreads. So it's either going to prevent the excess discharge at that one origin spot, or it's going to reduce its spreading throughout the brain. So if you have an excess discharge at one spot that doesn't spread, you may still have a seizure, but it may just be a partial seizure. You may just have a seizure in one area, but you're not going to have that full body seizure. Okay? if we can prevent the excessive discharge from one area, then hopefully we can prevent any seizure from starting, okay? So when we look at the anticonvulsants, we're looking at medications to help prevent seizures from starting, okay? And so Dilantin is one of those medications. Dilantin has a low therapeutic index. What we see with Dilantin quite often is individuals that are taking Dilantin will get that gingival hyperplasia. Okay, so they get that excessive growth of gingival tissue. We've talked about other medications previously that can cause this, but Dilantin is big, okay? So they get, we had individuals at the hospital that had seizure disorders that were taking Dilantin, and we were like routinely taking them to the operating room and cutting off all that excess gingiva. And it was because of the Dilantin. Phenobarbital is another anticonvulsant. The issue with phenobarbital is it will also increase that enzyme activity in the liver. And so therefore, if they're taking other medications, it's going to break down those medications quicker. Tegretol is another anticonvulsant. Tegretol is another one of those medications that are used for certain head pain, specifically trigeminal neuralgia. With trigeminal neuralgia, the individual is having nerve pain related to the trigeminal nerve. The problem with trigeminal neuralgia is it's very difficult to diagnose, and when the patients have symptoms, quite often they have symptoms of toothache. They have earache, toothache. If they have an earache and the ear looks good, then they just assume it must be a bad tooth. I have seen individuals with trigeminal neuralgia with multiple root canals, like trying to chase the pain, only to find out that all these teeth have had root canals now and they still have the pain. And because there's symptoms, I mean, they describe as symptoms of a toothache, okay? So Tegretol is quite often used for treatment of trigeminal neuralgia, and then it's also used for some psychiatric conditions. And then valproic acid, Depakote is the one, I think I've got a circle here in a minute, but the thing with valproic acid is that over time, you can start to see some changes within the blood. And they've seen conditions called aplastic anemia, agranulocytosis, which is just a dyscrasia that's involving the blood cells. And so, and this is related to valproic acid. So the ones I want you to know Dilantin, no phenobarbital, no Tegretol, and its generic is carbamazepine. I hate names of medications. And then Depakote. All right. Any questions? Everybody good with that? Okay. Well, the good news is you don't have a test next week. You have a quiz, but not the test. You have 2 other finals next week?
Yep. Great.
Is pain controls next week? Okay.
Yeah.